Good afternoon, the Vice Chancellor, Atiba University, Owo, the Dean, Faculty of Nursing Science, the HOD, Department of Nursing Science, all professors here seated, my professional colleagues. My name is Monen Samuel. I'm presenting this topic, translating theory into practice, the role of nursing process in clinical care. The content of this presentation is as shown. 1. The objective, the introduction, the importance of nursing process, the nursing process itself, conclusion and references. At the end of this presentation, students and everybody here present should be able to understand how to use critical thinking in nursing process. And students should be able to conduct assessment and recognize skills in data collection. They should also understand how to form nursing diagnosis and develop nursing care plan. And they will be able to implement nursing interventions and then evaluate the effectiveness of their intervention. Nurses translate theory into practice through critical thinking and clinical reasoning. Using critical thinking means we are taking extra steps. You are doing everything to make sure that the patient receives the right care. You want to validate patient information and make plans that are based on patient needs. Now, current clinical practice and research are imbibed into critical thinking and clinical reasoning. Integrating theory into practice is an essential component of clinical skill acquisition among nursing students. And the ability to effectively translate knowledge into practice is a key factor in achieving successful outcome and patient shifts. Clinical education forms the core of nursing education. Nurses rely much on our clinical education, which is the basis of our nursing education. Our ability to translate our nursing education into clinical practice is what makes us a nurse. And then it plays a key role in forming the identity of the nursing profession. Clinical learning activities provide a real-life learning experience and the opportunity to transfer knowledge into practical situation. Whatever you see, whatever you hear, whatever you touch, it will remain part of your knowledge for life. You can't forget it. Therefore, clinical learning activities is germane to nursing knowledge. The application of nursing scientific knowledge in practice is possible in the use of nursing theories and models in care. When you apply what we have learned in the theory, and then what all this nursing scientific knowledge that we have acquired, when you now apply it in practice, you are integrating theory into practice. Integration of theory into practice is influenced by several factors. The physical and emotional readiness of the students are germane to integrating theory into practice. And the educational preparation and the clinical experience also, they are very important, integrating theory into practice. And then also, in the individual factors, such as student knowledge level, and then the ability to theoretically, the ability to apply theoretical concepts to practice. they are very, they form factors that will influence integration of knowledge into practice. Therefore, ability to integrate skill and knowledge into practice are reflected by these factors. Why is nursing process important to nursing? About six decades ago, Ida Orlando first introduced nursing process in 1958, precisely. And then, because of that, this nursing process has, everybody throughout the world has imbibed this concept of nursing process. And then, nurses are the backbone of healthcare industry. They are the first person patients have contact with. Therefore, they care for others. Caring for others is the core of nursing practice. Therefore, the nursing process implies that patient-centered care is provided based on plan. Nursing process promotes efficient, effective use of time, and it enhances better communication practices between nurses, that is intra-professional, and between nurses and other professional body, that is intra-professional practices. The nursing process now, according to Ida Orlando, nursing process is divided into 5 segments: the assessment phase, the diagnosis phase, the planning phase, implementation phase, and evaluation phase. Assessment. Assessment is the first step in the nursing process, and then it involves critical thinking skill. Nursing must have the critical thinking skill. And then it also involves data collection. Nurses must be able to gather data information, either through objective or subjective means. Nurses' decisions makings involve using critical thinking and clinical reasoning. Critical thinking enhance our assessment. However, critical thinking is a broad term used in nursing that includes reasoning about clinical issues, such as teamwork, collaboration, and streamlining workflow. Using critical thinking means that nurses take extra steps to maintain patient safety and don't just follow order. It also means that the accuracy of patient information is validated and planned for. It also means the accuracy of patient information is validated and planned for caring for patients are based on their needs. We don't just make plan. We make plan based on patient needs and current clinical practices and research. The plan we make is very important, but it must be based on patient needs. It must be based on current clinical practices and research. We don't just base our information or our intervention on your personal experience that has not been validated. Therefore, it must be based on current clinical practice and it must be validated through research. And inductive and deductive reasoning and clinical judgment. The inductive and deductive reasoning are important clinical thinking skills. Before you can say you have a clinical thinking skill, you must have knowledge of inductive reasoning and then deductive reasoning. These two reasoning help in clinical judgment when implementing the nursing process. Inductive reasoning involves noticing cues. It involves making generalization and creating hypothesis. What do I mean by cues? Cues are abnormal data that you collected during your during data gathering. Therefore, all these abnormal variables is what you gather, and then when you gather it, you cluster it, you put them together. When you put them together, you add names to it. That's why we say making generalization. When Gnosy organize these cues into partners and create a generalization. The other time, what I mean is that when you make generalization is a judgment form from a set of facts, cues, and observations. When you have gathered your information, when you have gathered your cues, when you now put the related cues together, and then when you name it, you have made a generalization. That naming is what we call generalization, and then that is called Gnosy diagnosis, which form the label of Gnosy diagnosis. Based on generalization, the nurse create a hypothesis regarding a patient problem. When you are creating the hypothesis is a proposed explanation for a situation. You want to explain why the patient has the problem. I will explain in the next slide. Now, it's attempt to explain the why behind the problem. If a why is identified, then a solution can begin to be explored. When you know the reason for a problem, you can now identify a solution to that problem. But without knowing the cause of a problem, you may not be able to find solution to that problem. Let's look at this scenario. You will understand it better when I present this scenario to you. This 78 years old man, is admitted into main medical ward with a case of heart failure, and then he has been placed on 8 milligrams of IV lasers every morning. And therefore, the nurse during the morning assessment assessed that patient, and then he noticed that the patient body temperature was 37.1. The pulse is 100 beats per minute. The respiration is 18 cycles per minute. The BP is 9860 millimeter of mercury. Now, this patient went and checked the baseline vital signs of the patient. And then the baseline vital sign of the patient, the BP is around 110/70 millimeter of mercury, and the pulse rate is around 80s. Therefore, the nurse now took additional information. He now take the patient weight. He noticed that this patient has lost weight about 1.81 kg in the last 24 hours. The nurse also went ahead and asked this patient, "How do you feel?" And then the patient said, "Oh, I feel lightheadedness, and then I feel dry mouth, like I have cotton in my mouth." Therefore, the nurse now put these cues together. When he put these cues together, he now name it the cues. He may now make a Gnosy diagnosis of fluid volume deficit. Now that is the diagnosis he made. And then he made a plan immediately. The plan is that because this patient is taking IV lasers, this patient is not taking enough, is losing fluid. Planning outcome for re-establishing fluid balance. That is the planning. And then he also planned to withhold lasers and inform the management team. He now evaluates his actions after 24 hours. He noticed that the patient has gained enough fluid. He has achieved critical thinking and clinical judgment in nursing practice. Assessment. You recognize the cues. This nurse recognized the cues. the nurse will go ahead and make a nursing diagnosis based on the cues that he has identified. And because the patient is on IV lases, 80 milligrams every morning, this patient is losing fluid without taking enough. Now, the planning is that the nurse withhold the IV lases and establishing outcome for reestablishing fluid balance. And the nurse now he now inform the managing team that he has withheld IV lases so that so that the fluid volume or the fluid balance of the patient can be restored. And then at the end of the shift, this nurse evaluate his intervention, and then he noticed that fluid balance has been restored. About data collection. The data collection are into two types. Majorly, it's into two types: objective data and subjective data. The objective data is the data you collected through your instrument. For example, your lab results are of the objective data, or objective data are data that can be verified by another person. For example, if I'm coughing, everybody can hear that I'm coughing. If I'm sneezing, everybody know I'm sneezing. Therefore, they form the objective data. They are signs that is obvious to everybody. And then your vital signs that you do, they are objective data. It can be confirmed by anybody. Either you are using any instrument or machines to gather information, is an objective data. But subjective data is a data that's only presented by the patient. Only the patient can tell you what is happening. For example, if a patient is saying, I'm having headache, only the patient that can confirm that. Nobody can confirm whether it's having headache or not having headache. If the patient says, I'm having abdominal pain, it's only the patient that can say, I'm having abdominal pain. Nobody can say he's having abdominal pain. Only the patient can tell you that he's having abdominal pain. Therefore, any data that is not verifiable by any other person, that's only the person that says it that can tell you, is classified as subjective data. For example, the feelings that a patient presents is a subjective data. The perception is a subjective data. The thoughts is a subjective data. And then the sensation or concerns, they are all subjective data. And then data can also be verbal or non-verbal. The verbal includes what the patient says or what he writes. They constitute a verbal data. But non-verbal data is what the patient is not saying, but his body language is saying it. For example, patient can be having pain, but through squeezing of the eyes, gnashing of teeth, we know that this is presenting with a non-verbal data that you are noticing something. They are non-verbal, but they are body language. They are classified as non-verbal data. And then sources of data can be primary, secondary, or tertiary. The primary source is the one given by the patient himself. And then the secondary one is the one that are provided by the family members or any other person. And then the tertiary source is the one that you get from textbooks, that you use to confirm what the patient is saying or what you have got from your observation. They are called tertiary sources of data. Method of data collection. Method of data collections, we have the health interview. When a patient comes to the ward and then you sit down with the patient and you interview the patient, you are collecting data. you interview, and then you have a conversation, you ask questions from the patient, and then you are collecting data. And then when you now conduct a physical examination, from head to toe physical examination, you conduct inspection, you palpate the patient, and then you percuss to generate facts, and then you also ascoltate to elicit facts. These are constitute physical examination. And then observation is when you are just observing the patient. Like what I said the other time, that when you see a patient frown his face, is gesticulating, is restless. Therefore, you are using observation to collect data. For example, let's look at this. This is a patient. This is a nurse that is taking objective data from this patient. In this patient, this nurse is trying to elicit the pulse rate of the patient. We take the blood pressure, take the partial oxygen saturation of the patient. All this one constitute the objective data. Temperature, body temperature, pulse, respiration rate, BP, they constitute of the objective data. And the lab results, ESR, electrolyte, all this one you can get from the lab, they constitute objective data. And then the subjective data is the one you can see now. The patient, the nurse is interviewing the patient. Therefore, there's a relationship between the nurse and the patient is trying to elicit information by asking questions. Therefore, this one is called subjective data. Whatever the patient says is subjective data. Nursing diagnosis. Nursing diagnosis is what is the problem like. After you have identified the cues, that you have gathered the abnormal variables, now you cluster these variables. When you cluster and bring them together, for example, the first scenario I gave to you, this patient blood pressure dropped, and he has lost weight, and then he also said that he's feeling dryness in the mouth. When the nurse put this thing together, it clustered them. He came and then he had labels to it. He said fluid volume deficit. That is the nursing diagnosis. Nursing diagnosis statement. When you want to make a nursing diagnosis statement, you make it this way. You identify the problem. The problem is the nursing diagnosis, which is the label. You usually tag as the label. And then related factor. Related factor is the etiology, the cause of that problem. And then when you identify the cause of that problem, you now evidence by the signs and symptoms, the different characteristics. It forms that pattern. Fluid volume deficit related to IB lysis, inadequate fluid intake. And then evidenced by dry mouth, reduced blood pressure, and then reduced in body weight. Therefore, in establishing the related factor is usually related to these four things that are below. These things, the pathophysiology, you must be able to relate the nursing process to the pathophysiology of that disease condition, not the medical diagnosis. You can relate it to the treatment. For example, IB lysis that we are given that is making the patient to urinate excessively. It's a treatment. And then you can also relate it to situation. For example, if somebody lost his spouse, it's a situation. And then you can also relate it to maturation. For example, elderly or children, they are classified into maturation state. Therefore, these are the four things that we can relate nursing diagnosis to. You don't relate it to medical diagnosis. It's never done. The type of nursing diagnosis. The type of nursing diagnosis is we have the problem-focused nursing diagnosis, the risk nursing diagnosis, the awareness nursing diagnosis, and the syndrome nursing diagnosis. The problem-focused nursing diagnosis is the one that is we have the potential problem. This one, we have the potential problem, that is the problem focus nursing diagnosis. The patient comes with the problem. The problem has been identified. That is problem focus. For example, fluid volume, then deficient fluid volume is a problem focused nursing diagnosis. But the risk diagnosis is that this patient has never developed that problem, but you are anticipating that the other patient may develop that problem. And then you don't want the patient to develop that problem. You have taken it a risk nursing diagnosis. And then the other one is wellness nursing diagnosis. The wellness nursing diagnosis is that this patient is well, is not sick, but you don't want to be sick. You want to remain healthy. That is wellness nursing diagnosis. Syndrome nursing diagnosis, this is a conglomerate of nursing diagnosis that it has 2 or 3 nursing diagnoses that form a syndrome. When you treat it, you can only treat them together. You can't treat the nursing diagnosis individually. Therefore, it becomes a syndrome nursing diagnosis. For example, the problem-focused nursing diagnosis, what is the problem? The problem is presented at the time of assessment. That's the problem. Fluid volume excess related to excessive fluid intake, as evidenced by bilateral basilar crackles in the lungs, by bilateral pitioedema plus in the ankles and feet, and increased weight of 10 pounds over 1 week, and the patient report, my ankles feel swollen. These are potential nursing diagnosis. That is problem-focused nursing diagnosis or actual nursing diagnosis. But in the risk nursing diagnosis, the problem is likely to develop, but it has not been developed. Therefore, risk for fall, as evidenced by dizziness and decreased lower extremities strength. You are saying that if we allow this patient to walk on his own, he will fall. Therefore, you are working against fall. Therefore, you don't want the patient to fall. That is risk diagnosis. And then the health promotion diagnosis is that you are promoting health promotion nursing diagnosis. The patient don't want to come down with problem. Therefore, it's a motivation, desire to increase wellness or well-being or a patient's strength. For example, enhanced readiness for health promotion, as evidenced by expressed desire to learn more about health, so I can take better care of myself. The syndrome nursing diagnosis is a cluster of nursing diagnoses that occur together and are best addressed together. For example, risk for frail elderly syndrome related to activity intolerance, that's the first nursing diagnosis, social isolation, that's the second nursing diagnosis, and fear of falling, that is third nursing diagnosis. The 3 nursing diagnoses are put together to form a syndrome nursing diagnosis, and they are treated together. Planning. After your nursing diagnosis, you have to make plan. And then before you can make your plan, you must design the objective, what you want to achieve. And then that's what we call outcome identification. What do you want to achieve with your intervention? After you have made your outcome identification, you now make a plan. You write the goals and care plan. At this stage, this is the stage that we write the nursing care plan. And then we generate solution here. Let me also say that in this planning phase, this is a phase that you follow a Maslow hierarchy of need to make your nursing diagnosis, so that your nursing diagnoses are based on Maslow hierarchy of need. The one that comes first is the one that affects the oxygen, the one that affects respiration. Follow that up. The physiological needs come first. But in some cases, safety comes first, because you may be acting and something else happen. Therefore, you must ensure that you are safe first before you act. That's another dimension. Therefore, safety may come first in some situation. Component of nursing care plan, as we all know that the nursing care plan is the client health as assessment. That one is basic. And then the nursing diagnosis. And then you want to tell the expected outcomes, the nursing intervention, the rationale. For students, you must put down the rationale while you are proposing that intervention. And then you have to evaluate your intervention. Implementation. The nurse implement the identified plan. And then in implementing the identified plan, you must also use clinical thinking and clinical judgment. Clinical thinking, the other time when we are talking about that scenario, the nurse take extra step to verify the information because he noticed that the blood pressure is reducing. And then he went ahead and take the patient weight and then compare the baseline vital signs. Therefore, that is a critical thinking. And then continual patient reassessment is also necessary, as I just said. And then you prioritize planned intervention. Your intervention must be prioritized. It must be prioritized based on Maslow hierarchy of need and then based on the patient need. Assess patient safety during implementation. Yes, you must assess patient safety during implementation and then document interventions that you have performed on the patients. Evaluation. In the evaluation stage is you are doing reassessment. Again, because you have intervened, you want to assess or you want to evaluate your intervention. Do you meet your desired outcome? Do you meet it? Therefore, you need to collect data again, both objective and then subjective. And then you must also compare data with desired outcome and analyze the claim response relating to nursing activities. And then identify factors contributing to the success or failure of your intervention. You must identify those factors, especially when you are unable to meet the desired goal. You must identify why are you not meeting the desired goal. And then you continue modifying or you terminate the nursing care plan. If you achieve the desired goal, you terminate the nursing care plan. But if the desired goal is not achieved, you either continue or you modify your action plan. Planning for future nursing care. You have to plan for discharge during your planning stage. Conclusion. Assessment leads to diagnosis. Diagnosis brings outcome identification and then outcome identification stage is where you plan. Implementation and evaluation follows. Therefore, in the assessment, that is where you gather your data. You recognize cues. In your diagnosis, you identify the problem, and then you make your nursing diagnosis. That's the stage you analyze your cues. And then in your planning and outcome identification, that is where you prioritize your hypothesis. As I've said, you write the goals and care plan during outcome identification and planning. And then during implementation, this is where you generate solution. You generate solution to what you have to the problem. And then at the implementation stage, you also take action. You take action to implement what will solve the patient problem. And then at the end of the day, you evaluate your intervention, whether you are able to achieve what the outcome you have earlier identified. In conclusion, 2, assessment leads to diagnosis. Diagnosis guide planning. Planning informs the implementation. Implementation leads to evaluation, and then the nursing process is a dynamic and cyclical process. One leads to the other. If you start from as assessment and then you end in evaluation will still lead to assessment again. That's why it is called cyclical. Thank you for listening. That's my references.